All right, here goes. I know I missed the rest of the lecture for both the day and night class. So this is where the night class left off. And so it's going to be a little repetitive for the day class, for those of you that saw the first part, but we're going to give it a shot. I've never recorded like this before, so we'll see how it goes. But we're going to be talking about the pathophysiology, the assessment, and the management of obstructive upper airway diseases. And when we see here, when we talk about the pathophysiology, and this was in our quiz yesterday as well, is the tongue is the most common cause of airway obstructions, especially if the patient is unresponsive. So making sure that those tongue obstructions don't lead to death, especially in our presence. So these trauma patients, those in insulin shock, seizures, and also those that are intoxicated, they can end up becoming hypoxic, and that leads to bad things happening. So being aware of that. When we look at the anatomic obstruction of the tongue, the risks that come with that is any of the decreased level of consciousness, anybody that's altered or just really not able to protect their own airway. Some signs of that include snoring, gurgling, squeaking, bubbling, stridor, anything that you can hear from the doorway that you're like, that doesn't sound right. So if we have someone that has snoring respirations, we're going to want to open their airway with either a head tilt chin lift or a jaw thrust. Someone that's having gurgling, we're going to want to get our suction unit out and suction away whatever the liquid is that's causing the gurgling noises. Squeaking and bubbling, same thing. We're going to be thinking about something else up in their airway. And then stridor, we're going to be trying to figure out what the cause of the stridor is. Is they have smoke inhalation? Is it a kiddo with croup or epiglottitis? Any of those things, and then treating for what we find. Management of these patients, we don't want them to be laying down with their head on a pillow. It kind of makes the head go forward and it kind of kinks the airway that way. So we want to make sure that we don't have their head on a pillow. For kids, we even don't want to pad the head. We want to pad underneath the shoulders. We know that a lot of patients, and probably people that you know, maybe even yourself, could have obstructive sleep apnea, and that's that excessive tissue in the airway. I know the day class got a really cool visual I got to draw on the board for you guys. But just understanding that that excessive tissue in the airway, it's the tonsils, the uvula, the soft palate, and then even parts of the tongue can cause the obstruction. And the ways that they can get rid of that, if it's really severe, you can get rid of that via surgery and go to an ENT doctor, and they will do a tonsillectomy, adenoids and tonsillectomy, and take that out. And there's also the machines, the CPAP, that home CPAP that we see with patients have all the time. If we have somebody with a sleep apnea, we're gonna try to roll them on their side, put them in the recovery position. That seems to be the safest one and reduces some of that risk. Other things that can cause upper airway obstructions are going to be your inflammation caused by infection. So all of your kiddos that have croup or epiglottitis, that can be a cause of upper airway swelling, and the signs are going to be that hoarseness, barking cough, or that very distinctive stridor noise in that upper airway. Pusey, I'm not sure how to exactly say that. Pusey's law says that as the tube diameter decreases, resistance to flow increases. So the smaller a tube becomes, the more resistance there is to the flow, which makes sense. Think about a straw or water, really any water flowing, any liquid flowing through a tube. It's much easier to get it to go through a big tube than it is to go through a little tube. There's more resistance. The overall area becomes, exponentially smaller as the tube decreases. And this is why infections can cause, airway infections can cause croup in children, but not in adults, because as you get older and you get bigger and you grow, you have larger airway and you don't have that restriction. You don't get the restrictive disease that you do when you're a kid, because you because it doesn't get that small. Croup and tonsillitis are other common forms of airway obstructions, and they're pretty rare that we have serious issues now thanks to immunizations, but they can be extremely critical emergencies when they occur because obviously not getting oxygen, not getting air, not breathing, that usually leads to bad things happening. And when we have, especially those kiddos, we don't want to manipulate that airway if at all possible. So all of these croup and epiglottitis kiddos, we want the parents to do all of the work, all of the caring. Literally from the moment that I walk in, I say, okay, mom, like, or mom or dad who's riding with, or whatever caregiver is riding with, and from there, I say, okay, now we're gonna go out to the truck. Will you carry him out to the truck? Are you able to do that? And then once we get out there, I'm like, all right, I want you to put the pulse ox on their finger. Put it on your finger first, then put it on the kids. I'm doing everything I can possibly do to make the kid comfortable and not upset the kid, because the last thing I want is somebody that has a kiddo that has an upper airway infection to get angry or to get scared or to start to cry. And when that happens, more inflammation happens. Think about when you can tell someone's cried, that's had just had a crying jag because their eyes are all puffy and their nose is runny and they get more secretions. They might, and overall they might get a hoarse voice. All of those things can make the infection worse. And so we don't like to make kids mad. Promise. We don't like to scare them or anything. Let mom and dad do the majority of the work, and then that will usually help the kids from being so scared, and you don't poke the bear, basically. On that same note, you can see some of these upper airway inflammatory conditions, the infection. We've got croup, we've got epiglottitis, we've got, I have to get close, peritonsillar abscess, we've got the retropharyngeal abscess. So all those are going to be infections in that back of the throat, upper airway, as long as diphtheria and just enlarged tonsils in general. So keeping all of that in mind, all the different types of infection that can cause the upper airway obstructions. Overall, we don't want to try to intubate these patients unless it's our last ditch effort. Anything that you stick in that mouth and the throat, including a laryngoscope, can make the swelling worse and can make you cut down the airway already. If you do have the need to intubate, you're going to want to grab an endotracheal tube that's at least 2 sizes smaller than normal because there's already swelling in there. And then be prepared as your backup method if your laryngoscopy doesn't work, you might have to also do a cricothyrotomy, because if you close off that airway, you irritate it, you need to breathe for them, and that's going to be your backup plan. Some other things that we need to be aware of is aspiration and the risk of aspiration. And that could be anything from water when they're drinking, or they aspirated water because they drowned in a pool. It can be blood, vomit, food while they're eating. Especially we get a lot of aspiration calls for the newborn, even to like a year old, where they just choked, and first time mom or first time dad freaks out and they call 911 because they started to choke on some breast milk, whatever it is. And that is super normal and super something that you would expect to see. Hey, thanks. So that you expect to see at some point. Usually these kids are fine, but just be aware that aspiration does come with a big risk, because when you're not supposed to have anything in your lungs, that's why it's uncomfortable. That's why you cough and whatnot. And when you have that happen, then you have the risk of infection in your lungs, and that's not what we want. Some other patients that are specifically more prone to have aspiration are going to be your tube fed patients. After a tube feeding, they need to sit supine or upright they need to sit upright, not supine, excuse me, after they get fed. If they're placed in a supine position, like on their back or laid down, they have the risk of aspiration then. Any unresponsive patients obviously have the risk of aspiration, as well as your geriatric patients that have impaired swallowing, whether it be because they have Parkinson's disease or because they have ALS or whatever it is. Just be aware that that is a big risk factor for aspiration. And aspiration in these patients also has a pretty high mortality rate because they're already decreased. They're already at risk. Usually tube-fed patients aren't the healthiest patients. Geriatric patients that are already having trouble swallowing, not the healthiest. Unresponsive people, usually not healthy. They've got another issue going on. So be aware of those possibilities and those patients that are at risk. And then when we do have a patient that we know has a known aspiration, you're going to want to do an assessment, and you're going to want to see, did this start immediately after they were eating or tube feeding, or were they around something, particulate matter? You're going to want to really kind of investigate and ask a lot of questions to figure out, one, what is it that they aspirated, and two, how much did they aspirate, and then determine it from there. But they're probably going to need to go to definitive care to possibly get an antibiotic, especially if it went into their lungs. We want to make sure that we avoid any continuous like gastric distension. So when ventilating, so an NG tube is something that you might want to consider putting into their stomach after an aspiration. It's something that the hospital might do. I know we don't do a whole lot of NG tubes, especially around here, but that is something that's part of our curriculum. You want to make sure you continue to monitor the patient's airway and protect the patient's airway. If you have to use an advanced airway, go for it. You do want to aggressively treat aspiration with suction and airway control because hypoxia isn't good for anybody. Patients at risk of aspiration shouldn't eat when they're having difficulty breathing already, so making sure they don't continue to eat. We don't want to continue their tube feeding treatment. You want to discontinue it, that kind of thing. And then overall, just know that if basic maneuvers fail, what you're doing isn't working, you can always use your laryngoscope or your McGill forceps to dislodge something that's stuck as aspiration, or you can also, if it's still you're still not getting it out, it's a complete blockage or even a partial blockage that's causing quite a bit of distress, you can always use a needle or a surgical cricothyrotomy if allowed by your protocol. So making sure that you understand that, and you do want to treat aggressively because breathing's pretty important. When we look at lower airway disease and management of obstructive lower airway diseases, we're really going to be talking about COPD, asthma, and the obstruction into the actual lungs. And so when we talk about these are all irreversible, progressive chronic diseases. We can reverse some of the symptoms. We can treat and fix some of the symptoms, especially like if you look at asthma, we've got tons of different meds out there that we can reverse that narrowing of the airway. We can treat that narrowing of the airway. But in other patients with COPD, it's much harder to treat because it's been from damage and chronic damage to the lungs and to the airway. When we look at those with COPD, we're going to see some pretty classic conditions associated with each one. We'll see a lot of pursed lip breathing, because when they purse their lips and do the It allows for exhaling slowly under controlled pressure. So it allows for them to feel a little bit more in control and feel like it's a little bit more purposeful. We're going to see an increased inhalation to exhalation ratio. So typically in a normal healthy person, it's a 1 second inhalation to 2 second exhalation, and that's quiet in normal people. But gravely ill patients or patients that are really, really sick or having really bad asthma or COPD, they might have an inhalation to exhalation ratio as high as 1 to 6 or even 1 to 8. So being aware of that. We also want to look for abdominal muscle use, and if they're using their abdominal muscles to actually help push out the air during an exhalation, that's a bad sign. And then any jugular vein distension, any JVD, because that trapped air creates higher pressures in the thorax or in that mediastinum, and higher pressure means that the vessels that are in there are going to be under higher pressure too. So it'll be pressed on them, which will end up showing pressed on somebody's neck. So when we look at the pathophysiology for asthma, we see that bronchial asthma is really characterized specifically by increased trachea and bronchial activity by specific stimuli. It can be a widespread reversible narrowing of the airways, which are like a bronchospasm, and that makes it difficult to inhale. And we treat that we can pre-treat that, take prophylactic medications like a daily Advair. We also have rescue inhalers that patients can carry around. So the little metered dose inhaler, the rescue inhaler. But asthma overall, it affects 24 million people in America. And as we continue with better medical technology, and we consider we're doing more of a universal health care aspects, we're having more and more people be diagnosed, and the growth rate is fastest in children under 5, and understanding that is important, and that a lot of people are late to be diagnosed. And understanding also that patients with potentially fatal asthma often have severely compromised ventilation all the time, at risk of like acute bronchospasms, can be triggered by infection. We're going to use the term reactive airway. I have reactive airway disease. So I don't have asthma all the time. Exercise doesn't induce my asthma, but what does is when I have any sort of infection or any sort of sickness, illness, that little bit of inflammation triggers additional inflammation, and I end up having asthma symptoms. We want to be aware that our patients that have asthma are at a higher risk of respiratory arrest, and it can be really fatal, especially if they don't follow their medications or take their medications. And if you look here at the slide, you can see the different types of restriction, the bronchospasm where it tightens and it goes from being real big to real small. And then if you look at edema, we get that edema inside the airway, and it goes from being a big lumen to a crinkly, very much reduced lumen size. Here's that reactive airway disease, and patients with reactive airway disease are much more likely to be asymptomatic between these attacks, and they're usually brought on by a trigger. Like I said, my triggers being I'm sick or have an illness, but there's other triggers. It can be smoke. It could be certain seasonal allergies. It could be that your airway is reactive to lavender, whatever it is. But it can lead to severely compromised ventilations. And those with potentially fatal asthma usually have a history of it, and they can go into status asthmaticus or status asthma. And so we want to be aware of that. We want to look for other possible infections. We want to remove or mitigate the trigger. and we want to treat for if there is an underlying infection. We want to get that treated and taken care of as fast as possible. For those patients that we do find to be in status asthmaticus or status asthma, they're going to be really struggling to move air. You're going to see them accessory muscle use. They're going to have their chest hyperinflated because they can't get all the air out. They're having problems exhaling. They might even have completely inaudible breath sounds and wheezing. And they're, after a while, if they've been going through this for a bit, especially if they've been sick for a little bit, they're gonna be exhausted, they're gonna be severely acidotic, and they're gonna be dehydrated. So keeping all of that in mind. So when we think about that, we move to the treatment part. Or actually, we're going to touch on bronchospasms first. The bronchospasms, you're going to have that constricting muscle around the bronchi, and we saw a picture of it a couple slides back where it almost looks crinkly. It goes from being a straight round tube to all of a sudden it's like, it like collapses all together. And that can be from the stimulation from an allergen or irritant or whatever it was that caused it. So understanding that we want to treat with a bronchodilator, we want to make sure we treat with corticosteroids, and we also, we want to treat with a water and expectorants, treat with the corticosteroids, and treat with a bronchodilator. And so when we look at asthma and how we want to treat asthma, we're going to want to, how do I switch to the next slide now? There we go. We're going to want to be really conscious of any of the bronchial edema, the swelling, the wheezing, any of that stuff that we see, and any of the increased mucus production. And so when we talk about managing these asthma patients, the first thing we want to do is a nebulized bronchodilator medication. For us, we're going to want to start with a duo neb, and a duo neb that has ipratropium bromide and albuterol in it. If it's a severe bronchospasm, or if it's really bad, we're going to want to do the mag sulfate here as well. And then that's IV magnesium sulfate. And at the very last ditch effort, everything's going really poorly and we definitely need to do something else. You can do subcutaneous epinephrine. And we want to do 0.3 milligrams for an adult and subcutaneously, and you want to give it of the 1 to 1,000 epi. We also want to treat any of that bronchial edema with corticosteroids. Our corticosteroid that we use and we learn is salumedrol or methylprednisolone, and we give that for the patient's benefit, for the hospital's benefit, because it takes several hours for that really to take effect. It takes quite a bit of time. So we aren't going to see the results. You're not going to give them salumedrol and see instant results, but it will help them down the road for sure. If they have excessive mucus secretion, you're also going to want to consider getting an IV started and rehydrating them. Possibly, we don't really do like the mucolytic agents. We don't give like Mucinex or expectorants or anything, but it's something that you can also advise that perhaps the ER doc will recommend for them. Transport considerations, obviously, if it's an infection or continuous exposure to a trigger, you want to make sure you bring them somewhere where that won't be an issue. If they're still not improving, you're going to want to really consider somewhere that has a good ICU, someone that can, someplace that has ventilators and uses them regularly. I know all hospitals have the ability to intubate and ventilate, but you're not going to want to bring them to like a St. Mary's Southwest that doesn't have inpatient care when they're going to need to be monitored for a while. Again, consider IV fluids. Any place that when you're making the transport considerations, make sure if you have it that you don't have an airway, absolutely bring them to the nearest emergency department. But if it's a situation where you're managing them and they're stable, you're going to want to bring them to an appropriate facility that way. COPD and emphysema. COPD, which encapsulates emphysema and chronic bronchitis. Emphysema really destroys the terminal bronchial structures. It turns it from those nice little leaves at the end of the branches, turns it into like one massive blob of branch. It's really a restrictive airway disease, and it groups those little the individual little alveoli or individual leaves are then turned into like a large bleb, and they have less surface area for gas exchange because each circle has so much surface area, but when it turns into just a slightly bigger circle instead of a bunch of little circles, there is less surface area. And then when that happens, those blebs end up becoming weak and they can collapse upon themselves, especially during exhalation. And then it traps air in the alveoli, but there's not gas exchange happening. And so when we have patients that are having a COPD exacerbation, this is why we want to use CPAP, because we can force some of those collapsed airways back open. When we look at chronic bronchitis, this is the excessive sputum production on most days of the month for 3 or more months of the year for more than 2 years. So this isn't something that gets diagnosed overnight. This is something that takes at least 2 years to get diagnosed. But these are your patients that they're sick for a while. They have excessive mucus production, they cough up, it's a recurrent productive cough that's chronic. Normally these patients also have abnormal arterial blood gas levels, and these patients, the chronic bronchitis patients, are usually heavy smokers and or overweight. And these are called your blue bloaters because they often have a bluish complexion. But normally these patients usually have a very elevated partial pressure of carbon dioxide and a decreased level of the partial pressure of oxygen in their blood levels. Jumping back to emphysema, emphysema patients are going to be more of your barrel-chested. They're going to be with little toothpicks for limbs, but they're barrel-chested from that chronic hyperinflation. They also tend to be a little bit faster breathers, as well as that barrel chest has a larger muscle mass because it takes more energy, and they breathe more and they hyperinflate, and so they'll be a little bit musclier around their thorax as well. The causes of diffuse wheezing for these patients is usually going to be left-sided heart failure, or it can be any of these things, but it can be left-sided heart failure, and that is known as cardiac asthma. It also can be from smoke inhalation, whether it's voluntary like cigarette smoke inhalation or they were caught in a fire. Chronic bronchitis can lead to diffuse wheezing as well as acute pulmonary embolisms. So, excuse me. Causes of localized wheezing is usually going to be from an obstruction from a foreign body or a tumor. So if you have a localized wheezing to one spot, that's when you're going to hear it. It's going to be there's a foreign body or there's something in there. COPD with pneumonia, that puts them at such a bigger risk. With COPD, any of these patients that have some kind of chronic disease, they end up having more frequent lung infections. And any of these patients, you really want to check to see if they have a fever, any coloration changes in their sputum, any other signs of infection, and really, really listen to breath sounds, because with these COPD patients, they're going to have a little bit abnormal breath sounds at baseline, but you're going to want to listen for those that are consistent with pneumonia or an infection in lungs as well. So in addition to having a little bit of diffuse wheezing or even local, like of the diffuse wheezing, they're also going to have that rhonchi noise as well. So making sure that you're looking out for that. COPD with right-sided heart failure. It's really difficult for the right side of the heart to push thick blood from polycythemia through the capillaries, especially those capillaries that are compressed by hyperinflated alveoli. Or in other words, you're right, when you have right-sided heart failure, you tend to when you have right-sided heart failure, you tend to have these things, right? You're looking for the peripheral edema, JVD, crackles at the end of inspiration, difficulty breathing, yeah, all of these things. And when we know that a patient has this, we can try to counteract it by, regulating their fluid intake and having them see their doctor and all of those things as well. COPD patients with left-sided heart failure. The left-sided heart failure is the ventricular dysfunction and can cause it's caused by ventricular dysfunction. Obviously, we learned about that last module. But you need to make sure that you're not lumping, your patient doesn't just have to have one thing wrong with them. So the initial impression of COPD shouldn't rule out that they're having an MI or they're having left-sided heart failure, because patients can have more than one thing wrong with them at a time. So making sure that you, if they're having any kind of chest pain, that you're looking for chest pain, you're looking for the 12 lead, you're doing a full assessment as well. And then what we really see that the times that we get real aggressive with our treatment is when we have acute exacerbation of COPD, and that's like a sudden decompensation, and it's not because they have another illness, it's not because they're sick or because they got exposed to smoke, but it can just be from environmental changes. And that environmental change could be that today it's 90 degrees and humid, where yesterday it was 70 degrees and sunny and comfortable. That sudden change can trigger, it can be triggered by like an inhalation or trigger from a substance. So maybe they got too close to the magnolia tree and that's their trigger, whatever it is. Just knowing how to then deal with it is important. When we talk about those with COPD, we can talk about end-stage chronic COPD, and that's when we get into the more sad cases. The lungs can no longer support oxygenation on these patients. Oxygenation and ventilation is just too hard, and it just doesn't work. Some of these patients might be put in hospice care. I think I've seen a lot from personal experience. I've seen a lot of these patients be the ones that like the stubborn old smokers, and they don't want to go into hospice. They don't want to do anything. They just want to be left alone. However, they don't want to be left alone when all of a sudden they're actively dying from a COPD exacerbation. So it really is difficult to know if we can resolve these issues. I've had a couple patients that I've brought in that I was sure they were going to die. They were regulars, and it was finally the COPD day that I was like, oh, well, that one's it. And I kept them alive all the way to the hospital. I kept breathing for them, and I did all the things. And when I handed them over, I was like, I'm probably never going to see Gary again. And then go figure, that one time was the time that really woke them up that they needed to manage it better. And I did see Gary again, but not with a COPD exacerbation. It was for something else. But keeping that in mind, that you want to make sure that you're doing what's in the best interest of the patient, especially when they are at the end stage. and really making sure you understand what the patient's wishes are and what the family wishes and all of those things as well. COPD and trauma. COPD lessens the person's ability to tolerate trauma, right? They're already struggling to breathe. They're already having decreased ability for oxygenation and ventilation. And when you introduce a trauma in there as well, they can definitely decompensate rather quickly. And I do want you to remember that normal oxygen saturation for these patients might be less than 90%. And so a saturation of 98% isn't really realistic at all. So if you're able to and your patient's able to answer, you want to ask what their baseline oxygenation is. And really for these patients, you want to keep them above 90 seems to be the goal. But ask them what it is and then adjust from there. Don't worry so much about the number that the patient has, but how the patient is acting. Read your patient, not your monitor in this case. So as long as they don't look like they're gasping for breath and they're not turning blue and they seem to have good circulation and whatnot, be okay with their 91% pulse ox. Because they're not, sometimes that's as best as they're going to get. On that same note, we do want to immediately help if they're in quite a bit of distress. You don't want to worsen the situation. So you want to try to figure out what caused it and eliminate that from the problem. I think I talked already about hypoxic drive, but I can't remember if I did it for the night class as well, so I'll briefly touch over it. But that hypoxic drive, most of us are all driven to breathe via the amount of carbon dioxide in our system. However, a lot of COPD patients, most COPD patients eventually lose their ability to have carbon dioxide be what drives them. And so rather than the carbon dioxide, their respiratory drive is driven by the presence of oxygen. And when they have if we give them a whole bunch of oxygen, if we give them and just bombard them with oxygen, their body is reading all of that oxygen and being like, oh man, I don't need to breathe. I've got all the oxygen that I need. And we can decrease the respiratory drive that way. And so we want to make sure that we're using our critical thinking skills when we administer oxygen, especially to these patients. It's really impossible to know which patients breathe because of the hypoxic drive and which ones don't. You want to keep encouraging breathing. You want to make sure that you're, keeping a close eye on them. If you kill off their hypoxic drive, you want to make sure that you give them artificial ventilations, you breathe for them. You even might want to consider intubation at that point. But oxygen saturation values are really not that useful in patients with COPD because they're on their own scale, and each person is on their own individual scale, not a COPD scale, but each person has their own measurements that they really know. But overall, what I really want you to take from it is I don't want you to withhold oxygen for fear of decreasing someone's respiratory drive. It usually takes quite an extended period of time to decrease that respiratory drive. And when I say extended period, I mean hours, not so much minutes. So if you have somebody that's struggling to breathe, please give them oxygen. On that same note, auto PEEP. Auto PEEP allows for the complete exhalation before the next breath of ventilation. And then you do want to keep some pressure in the thorax, especially with those COPD patients, because those blebs or those end terminal airway pockets collapse without any pressure. So it is necessary to keep some peak end expiratory pressure in these patients. And these patients should be ventilated at 4 to 6 times per minute, which is not our normal values, right? That's definitely slower than what we normally would. Some other common respiratory conditions we're going to talk about here here, we're going to look at different infections caused by bacteria, viruses, fungi, protozoa, and other organisms as well. But infectious disease causes swelling of the respiratory tissues. It can cause increased mucus production, as I'm feeling right now, as I have this upper respiratory thing going on, and I'm going to use a tissue here in a second. And then production of pus. Resistance to airflow increases as the airway diameter is narrowed. Again, there's Say's law. I don't know how to say that. I'm probably saying it wrong. It's fine. But that I want you to know this. There's a reason why it showed up multiple times, right? We need to know this one right here. I'm just covering it up. That's not helpful at all. But make sure you get that in there. Understand also that if the alveoli becomes filled with pus, it's not a functioning alveoli. That can happen with the chronic bronchitis, or it can happen, pus comes with an infection, but being aware of that. People that are at a greater risk of pneumonia are going to be all the ones that you expected it to be. It's going to be your older population, people that already have a chronic illness, smokers, anyone that has excessive secretions, immunocompromised people, all of those things make sense. Specifically, those that are immunocompromised are more likely to get some specific types of pneumonia, but all high-risk patients are strongly encouraged to get a pneumonia vaccine. Because we do get to the point now, we've developed so many drugs to treat it, but these bacteria and whatnot and these viruses are able to mutate and evolve, and now we've got antibiotic resistance organisms that someone gets one of those, like a super bug, there's not a whole lot we can do for them. When we do have these patients, some of our assessment techniques should involve getting the report of how long it's been going on, talk about the cough, talk about the fever, get information about that, and have them describe any chest pain. Some of these symptoms, it can happen abruptly, where all of a sudden they wake up and boom, they're super sick, or it can happen gradually, where they just get sicker and sicker and sicker. When we look at these patients, normally they look pretty sick. They don't look very healthy when they have pneumonia. They may not necessarily be coughing, but you should hear the bronchi in their lungs. They're also going to have increased that tactile fremitus, or that vibrations that you can feel in the chest. They should have that sputum production, excessive sputum production. And then they might have the bronchial or bronchiovesicular breath sounds over a certain area. In more advanced cases, you might see diminished or absent breath sounds. You might see thick, purulent, or really discolored sputum. Patients might even complain of chest pain when they breathe. And you might even hear like a pleural friction rub over an area if they're having a lot of difficulty there. Pneumonia usually occurs in the lung bases. These patients are often dehydrated as well, and they're dehydrated because they usually have an increased respiratory rate, because they have a decreased oxygen surface area, a decreased area for gas exchange because of the pneumonia, and so they're getting a lower level of oxygen than they're used to, so they're going to breathe more. Their body compensates. When you breathe more, you're also getting rid of more water, so you can become dehydrated. You're probably also not feeling good, so you're probably not doing the stuff you normally do. You're probably not drinking a lot or eating a lot, and you're getting less fluids that way. Supportive care for these patients, you're going to want to give them oxygen as appropriate to keep them above 94%. If you need to suction any of their secretions, friggin' gross, but if you might need to suction secretions, and you can take them to pretty much any facility, any hospital. ER should be able to care for somebody with pneumonia. Really, really bad like sepsis pneumonia, you're probably going to want to bring to a bigger hospital. But anybody that just has like bad cold and looks crummy should be able to be treated anywhere. Again, upper airway infections do require more aggressive airway management treatment. We don't want someone's airway to completely become occluded, because then we don't have any way to breathe for them. Lower airway infections, really we need to give supportive care and get them to a facility that can, for definitive care, and treat them. Atelectasis, our alveoli are vulnerable to many different disorders, and alveoli can collapse from obstruction in any of the more proximal airways, or even from external pressure. They could fill with pus, they can fill with blood or fluid, and they can be damaged from smoke or toxins. But what we really need to make sure is that we understand is that 79% of the airway that 79% of the air that moves in the lungs is into the lungs is gas, and it's nitrogen, and that nitrogen gas helps keep the alveoli open as well. And when a patient is given 100% oxygen, any alveoli that is plugged will collapse when the oxygen diffuses out, and that can cause atelectasis. So this is why we really like CPAP. We have that the continuous positive airway pressure. This is really why we try not to give people 100% oxygen for long periods of time, because it can cause more problems. It is common for some alveoli in the human body to collapse from time to time. It's not uncommon for that to happen. Sighing, coughing, sneezing, any changes in position can help open closed alveoli. And when those things don't work, when those actions don't work, the number of when we want to increase the number of alveoli, we want to make sure that we're just preventing any further collapse, right? And so hopefully eventually those alveoli will open back up, but we want to prevent any more from collapsing. Those areas that have collapsed alveoli do have an increased chance of getting pneumonia, so we don't want that to happen either. Assessment, make sure that the affected area, for atelectasis can harbor pathogens, right? We trap the airway, or the alveoli collapse, the tubes collapse, and it traps air in those pockets. Well, it doesn't just trap air, it can trap pathogens in there as well. So you do want to check to make sure if anybody that has a fever has had any recent chest or abdominal surgery. You want to check for any abnormal sputum. Anything abnormal would be anything super like white or pearly, or anything that's green, brown, pink, anything that's not what you would expect to see, right? Just making sure you're looking for that as well. Post-surgical patients are encouraged to get out of bed, walk around, cough, breathe deeply. They use those spirometers. You've probably seen this guy at some point. If you've ever had anyone have surgery, they have a bunch of those, and that just helps. It helps the patient to practice deep breathing. It gives them a target, it gives them a goal, it gives the respiratory therapist a way to measure the quality of their breaths and how they're doing. And sometimes they even give you incentives to do it too. So encouraging that. You might see those in the homes of some of your patients. Moving on to cancer is another pathology that we see. Lung cancer is one of the most common forms of cancer. Usually it's most commonly caused by cigarette smoking, but there also are occupational hazards. There's asbestos that people were exposed to, people that worked in mines, people that did certain jobs, anybody that worked with baby powder. There's a whole bunch of crazy things now that they found that's a carcinogen and that leads to lung cancer specifically. But smoking, it really contributes 80 to 90% of the new lung cancer cases. So keeping that in mind and discouraging smoking. Smoking is bad. But cancer, often one of the first signs of cancer is coughing up blood in the sputum, or the hemoptysis. Coughing up blood in the sputum. And usually associated with that is also going to be uncontrollable coughing, especially when there's large tumors in the airway. COPD and impaired lung function frequently accompanies lung cancer, which makes it even worse because you already have an issue and now you're building another issue on top of it. And then cancer from other body sites can often metastasize in the lungs. And if you think about why that happens, the metastasis happens normally when the cancer cells make their way into the bloodstream. And it really makes sense why we end up having lung cancer, because all of our blood filters through our lungs multiple times a minute even. So the chance for those cancer cells to lodge or displace or whatever, or place themselves in the lungs is super high. Makes sense. Other cancers may invade the lymph nodes in the neck. Radiation chemotherapy might cause some pulmonary complications that way, but overall, you're going to want to treat the cancer, because if you're dead, then then that's bad. That's worse than causing pulmonary complications, obviously. Let's see. Some of the on that last side, some of those the tumors and treatments can also cause pleural effusion as well. But little prehospital treatment, there isn't very much prehospital treatment for pleural effusions, or even for bloody sputum, other than really supportive care and transport to the hospital. If they're low on oxygen, give them some oxygen. If they're in pain, give them pain management. A lot of times we're called for these end-of-life issues, and the spouses or patients or children or whoever's taking care of them panic, because when they're at their end of their life, they don't want them to be at their end of their life, but they don't know what to do. They panic. Maybe the hospice nurse didn't answer on the first ring, and so now they called 911. But people are programmed to call 911 when something's horribly wrong. So it makes sense why we would be called for these situations. The big thing on here is a lot of these end-of-life patients, these hospice patients, are going to be on very high doses of narcotics to treat the pain, to keep them comfortable. And I really want you to be hesitant in delivering Narcan or naloxone to these patients, because you can make them miserable. When I say they're on a lot of morphine, normal morphine, we learned in cardiology, is 2 to 4 milligrams with a max of 10. Some of these patients take 50 milligrams of morphine at a time. 50. And granted, it's oral, so it's really less than that because of the way that it's processed and digested and whatnot. But still, that's a lot of friggin' morphine. And the last thing you want to do is give them a whole bunch of Narcan and bring all of their pain back. So if you do need to give Narcan or naloxone, you only want to titrate it to improve respirations. You do not want to reverse the patient's pain control method. There is also, we want to consider toxic inhalation as a cause or as a contributing cause to airway obstructions, airway damage. A lot of what we'll look at and what we'll see, the ones that are toxic to us are those that are really good at dissolving into water. They're highly water soluble, such as ammonia. It can be an acute upper airway irritant. Chlorine is another one. Depending on the concentration and the amount of exposure and whatnot, it can do everything from just causing irritation to the airway to giving you full-blown like pulmonary edema and chemical burns inside your lungs. There's also phosgene. We don't really see that so much anymore. I can't remember what it was in at the time, but it used to be, I think, it was a farm chemical, but phosgene really was bad for your lungs, and it gave you a delayed onset of pulmonary edema, so you didn't even know what caused it. But that's not really something that's very popular anymore because of that reason. But those highly water-soluble gases react with your moist mucous membranes. Makes sense. You've got moist, lungs and airway and everything, and it can cause a lot of swelling and inflammation. Some of the less water-soluble gases can get deeper into your airway because of that, and it's not that they won't cause a more acute problem immediately, but they can cause more damage over time because they're making it farther into your airway, such as nitrogen dioxide, phosgene. Those things can cause longer-term damage from long-term exposure. Some of those moderately water-soluble gases will give you signs of irritation and maybe some pulmonary edema, usually somewhere in between, such as mixing drain cleaner and chlorine bleach can give you an irritant of chlorine gas. It's pretty toxic. In other industrial settings, pools, water treatment plants, aquariums, the zoo, all the hospitals, any of those large facilities will have higher concentrations than what home use will have as well. How we want to manage these patients, we want to immediately remove them with the contact from the gas. Hopefully they have already been removed, but you don't want to be exposed to it, so make the fire department go in with their SCBA and safely remove the patient. Once you get them, you want to put them on 100% oxygen or assist their ventilations. And they may require more aggressive airway management where they might need to be intubated depending on how severe it is. Exposure to only slightly water-soluble gases, initially they're going to feel pretty fine, but you're really going to want to transport them to the emergency department for observation. Anytime they've had a really significant chemical exposure, even if they feel fine now, they can have really acute symptoms develop sometimes hours later. So making sure they understand that and that you warn them of that as well. That pulmonary edema, it's going to be that fluid build up in the lungs. The blood plasma fluid kind of leaks through that. It leaks through that single layer of cells. And what it does is it ends up compromising gas exchange. And then when pulmonary edema is officially classified, there can be two different types. There's high pressure and high permeability. High pressure is a cardiogenic cause, so that's going to be the pulmonary edema we've already talked about back in cardiology. That's going to be your heart failures or right or left ventricular dysfunction or chronic hypertension or whatever. But high permeability is your non-cardiogenic causes, and that occurs in acute hypoxemia, and then when you have damage to the pulmonary capillaries by either toxins or drugs in the bloodstream. So being aware of that. We're going to assess these patients. You're probably going to hear some crackles or rails. It's because that fluid leaked out of the capillaries, and you're going to have increased diffusion space between the capillaries and alveoli. They're going to be more swollen, and eventually it's begin to seep into the alveoli. So you're going to have that leakiness in the alveoli. You want to listen to those lower lobes through the back, and it's going to be a really soft sound. Especially initially, it's going to be a really soft sound, so you're going to have to listen very closely and quietly. As patients get worse, you're going to be able to hear it farther up into their lungs, and you're going to be able to hear it clearer as it gets worse, which makes sense. More fluid, more noises. But as it worsens, patients may start to cough up that watery sputum, that pink tinge sputum from those red blood cells. It might not always be pink, it could be white, but it's going to look like it's going to be like a foamy sputum. It's not going to be, it's going to look like they have rabies. That's what it's going to look like. In our management of these patients, you really want to at least identify, if not treat, the underlying cause. Are we able to fix everything? No, but having a good idea of why it's happening will make it so that definitive care can be delivered quicker. You want to maintain good oxygen saturation levels. If you're able to, it's better if you do a non-invasive positive pressure ventilation, so get that CPAP in there and to keep the alveoli inflated. And that will also relieve preload and afterload. You consider nitrates to lower their afterload, so you consider giving them a nitroglycerin, the 0.4 nitro sublingual. This will increase their stroke volume, increase cardiac output, but it also lowers that afterload, which is the important part. ARDS, or acute respiratory distress syndrome, or shock lung, or if you're from Eastern Hemisphere, Da Nang lung. Really, for us, it's really seldom seen in the field. This is caused more by diffuse damage to the alveoli from either shock or aspiration or pulmonary edema, barotrauma, hypoxic event. All of these things can cause ARDS. And really, ARDS is again, it's just that acute respiratory distress syndrome. It's when they get to the point where that's what's happened, like they're just so bad. So we saw ARDS with a lot of our communicable diseases, and one of the end stages was ARDS because the infection just completely rocked their lung system. It's obviously going to be worse with direct damage to the lungs. The alveoli end up becoming stiff and they're difficult to ventilate. These patients usually have a very poor prognosis. But when you have these patients, these ARD patients, you're going to want to do a good assessment. You're going to want to document all of the normal stuff, oxygen saturation, breath sounds, any changes. You're going to want to monitor everything. You're going to want to keep your low tidal volumes, inverse inspiration to expiration ratios. And then there is a certain amount of permissive hypercapnia that can be approved. So if they have a higher level of carbon dioxide levels, that's almost okay in these patients. Not excessive, but a little bit higher, you're kind of okay with it. And then we're going to talk, I think this is our last subject. We've only got 12 slides left, so hopefully I can power through this. But we're going to talk about the pathophysiology assessment and management of conditions outside the lung parenchyma. So a pneumothorax. This is going to be talked more about in trauma, but air collects between the visceral and parietal layer of the lungs. So that outer layer of the lungs, we've got the visceral layer that's on top of the organ and the parietal layer that's on the outside. And when air collects in between those two layers, which normally has pleural fluid, having one of my moments. It has a almost like a surfactant, or that has a fluid in there to keep those two layers of the lungs from rubbing together too much, because it's painful when they rub together. So if air starts collecting in there, well, it doesn't hurt because they're not rubbing together, but it probably hurts for a different reason. Some of the spots where a pneumothorax is more likely to occur is in those blebs, or in those weak spots. And those spots can rupture when they're under stress, and it can be predisposed to these COPD patients are more likely to get a pneumothorax from positive pressure ventilations, especially aggressive positive pressure ventilations, because of those blebs. The other susceptible people are going to be those with asthma, your smokers, those that are really tall and thin. For whatever reason, tall and thin, I mean, you're like a stretched out, really like those tall and thin, usually young guys can have those spontaneous pneumothoraxes. Patients may have a sharp pain after coughing. They might have increasing difficulty breathing, especially in subsequent minutes or even hours. Sometimes it might take a little while to realize that you've got that. Especially those young, healthy, super tall, skinny guys. They have like a sharp pain on their side, but they've got a whole nother lung that's oxygenating them well enough. They've got pain, but man, they have pain sometimes frequently. Well, they don't think too much of it. And then as time goes on, more and more of the air fills up more and more in that space between the two layers, and it becomes harder and harder and harder to breathe. And then hours later, they're like, maybe I should call 911 because I can't breathe now. So keeping that in mind. Most of our pneumothorax patients won't require acute intervention. Oxygen and close monitoring of the respiratory status is usually adequate enough to get them to the hospital. When we need to intervene is when they have a tension pneumothorax, and immediate intervention with a needle decompression is what we want to do for those tension pneumothoraxes to relieve that interthoracic pressure of the mediastinum area. How do we know when? Nope, that's, of course, it's not going to tell me that. But just to go back, just to briefly talk about that, when we know it's a tension pneumothorax from a regular pneumothorax, is the increased difficulty in breathing. We're going to see unstable hemodynamically. You're going to see absent lung sounds on the one side. Later signs are going to be JVD and trachea deviation, but decreased oxygen saturation. Anything that starts to show that they're unstable, go ahead and dart them. Pleural effusion. So pleural effusion is basically a sac of fluid similar to a blister that's formed when fluid collects between the visceral and parietal pleura, the two layers of the outer layers of the lungs. It can be caused by infection, tumors, or trauma, but that lung tissue rubs against each other, and it causes inflammation and fluid accumulation. Pleural effusions can contain up to several liters of fluid. And large pleural effusions decrease the lungs' capacity and causes difficulty breathing. So if you've ever heard of the pleural effusions before, you know that sometimes the hospital goes in and has to drain those. That's not something that we do, though. With pleural effusions, it's much harder to hear their breath sounds. The patient's position will affect the ability to breathe as well, depending on how the fluid's sitting and where their pressure's pushing and whatnot. So they might be positionally, they might have positional dyspnea. Likely the Fowler's position is going to be the most comfortable. And they might shift into other positions, but likely they'll shift back to the Fowler's position. Supportive care to the hospital is really what we need to do for these patients. And then the thoracentesis is the draining of the large pleural effusion. Pulmonary embolism, we did already talk about this more towards the beginning of yesterday, but pulmonary embolism is when a blood clot or some kind of clot embolus, it can be a fat embolus from a broken bone, an amniotic fluid embolism during pregnancy, an air embolism from like a neck laceration or a faulty IV, or if you didn't flush your line, you can cause an air embolism. But it compromises that pulmonary circulation by lodging in the vein, or nope, that'd be an artery, by lodging in the artery that's headed, because it's the pulmonary artery that heads towards the lungs, and it gets smaller and smaller and smaller until it hits the capillary bed. So wherever it can't pass, it's too large to pass, that's where it gets lodged, and then things start to back up. And what happens if you've ever seen like a flooded river? Think about a flooded river, and a branch, like a log, gets stuck. What happens when that log gets stuck? Other logs get stuck, other branches get stuck. So you might have a PE that starts, way down towards like a terminal end of the branch, but as that blocks up, it's blocking things behind it, so it can lead to an even bigger blockage. So it's important to be aware of that. And what happens is that that deoxygenated blood can't reach the alveoli, so we can't oxygenate it, and we lead to hypoxia. Makes sense. Some early presentations of a pulmonary embolism, they're probably going to have normal breath sounds. They'll have good peripheral aeration, and a lot of times these pulmonary embolisms have a pretty confusing presentation, because they really don't have to follow anything. You would have asymptomatic pulmonary embolisms all up until the point where all of a sudden you turn blue and you keel over and you die. That doesn't usually happen that way. The more classic presentation is going to be that sudden onset of difficulty breathing with cyanosis, possibly with like that pinpoint sharp chest pain, and that the cyanosis doesn't end with oxygen therapy. There's no changes with the amount of oxygen you give them, or very small changes. Often pulmonary embolisms begin in large leg veins, and like your great saphenous vein, or the other veins there in your leg. But what happens is that they then migrate back up into the heart. They go back into, they're headed back towards the venous circulation back to the heart. It goes through the heart, it goes through the right atrium, goes to the right ventricle, then it kicks out that pulmonary artery and goes to the lungs. And that's why it's such a big risk, because that's the first place that there's really a net or a shield or smaller spots. Because if you get a clot from your, like a deep vein thrombosis, right? You get a clot from your leg vein. When things are returning to the heart, all those vessels are just getting bigger and bigger and bigger as they return to the heart. And then through the heart, there's no filter in the heart. There's nothing in there. It just has to make it through the valves, and there's so much pressure built up there that it sucks it right through. And the first time it runs into really an issue is when it reaches the pulmonary circulation. Some of those clots can be developed by immobility. They can be developed by long periods of travel, recent surgeries. They can be developed by smokers, birth control. All of those give you a greater risk as well. Oftentimes, bedridden patients are given anticoagulants and like the special stockings or support hose, and they also use like the air inflation devices on their calves in the hospital. I know I was in the hospital for about a week 2 summers ago, and by I think the 4th or 5th day, they wanted to give me Lovenox. They wanted to give me anticoagulants, and I was like, can I just take a walk instead? But knowing that they do, it's like almost an automatic treatment for those that are in the hospital for an extended period of time. Just because you're in the hospital bed for 23 or more, 24 hours a day, without getting up and doing a whole lot of moving around, and it makes you more susceptible to PEs. Again, the inferior vena cava, an inferior vena cava filter is a potential management of PEs. They can be inserted into patients with a history of DVTs. Like I said, there's no filter up until they get to the lungs, and so if we can insert this filter, it opens up almost like a mesh umbrella, and then it catches any traveling clots that are coming from the legs or anywhere else in the body in that inferior vena cava. And there now have a recent shift to the recent studies are more in favor of removable filters that won't erode through the blood vessel after treatment's complete. So they're coming up with new ideas. And then saddle embolus. This is an exceptionally large embolus that's lodged right at that bifurcation at the left and right pulmonary artery. And it can be immediately fatal. If a big enough clot lodges right there, boom, there's nothing you can do. These patients have CAPE cyanosis, which is a deep cyanosis of the face, neck, chest, and back, and that's despite quality CPR and ventilations with 100% oxygen. There's just not a whole lot you can do for these patients. I think you should take 30 seconds and grab your phone and Google saddle embolus. And you'll be amazed at how freaking big these blood clots are if you've never done it before. But an hour and 15 minutes later, that's the end of the lecture. I hope you had the chance to watch this before next week, Monday. If you made it all the way to this point, come see me and I'll give you a Dorsey dollar for doing extra work outside of class. Thanks for hearing me lecture, even with my stuffed nose, and I will see y'all tomorrow. Thank you.